Hello, my name is Ravi Vij. I'm Chief Medical Officer at My Cancer Haven. My Cancer Haven is a 501c3 organization with a mission to improve the quality of information, support, and care available to every person facing blood cancer. I'm excited today to welcome you to our roundtable series, CLL Today, Integrating Innovation into Everyday Practice. This program is supported by an independent educational grant by B1 Medicines, and the program production has been provided by Cancer Communicator. In today's episode, we will be focusing on current treatment. To aid this discussion, we are joined by two illustrious faculty members, Dr. Bita Fakhri, who is Assistant Professor in the Division of Hematology, Director of CLL Clinical Trials at Stanford in California, and Dr. Nitin Jain, who is Professor of Medicine in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. So welcome, Bita. Welcome, Nitin.
Thank you for having me, and great to be here with you, and great to be here with Nitin.
Yeah, excited to be here as well. Looking forward to the discussion.
Okay, so I'm going to start out with you, Nitin. So could you walk me through how you choose treatment for a patient who is eligible for any of the NCCN guideline recommended treatments? For example, let's start off with a fit treatment-naive patient under 65 with unmutated IGHV and no TP53 aberration. What are the factors that are driving your choice in such a patient?
So it looks like you're describing a patient who's a young, fit patient, but IGHV unmutated region, which I think is a very important factor, and also without deletion 17p or TP53 mutation. So currently, if you look at the NCCN guidelines, we have several options available. So one thing I would say is that the chemotherapy should absolutely not be used for patients with CLL. So that is completely out of the picture. But if you look at the target therapies, right, we have multiple options. The first one, which was approved, was a continuous BTK inhibitors therapy, and we have three of them: ibrutinib, acalabrutinib, zanubrutinib. Ibrutinib has fallen out of favor because of the toxicity issues. So really, at least in the United States, we're using either acala or zanu, which are continuous daily therapies. And then we have time-limited approaches, and we have two of them available. One has been available for a while, Ven plus obinutuzumab, which has been there for a while, approved based on a trial called CLL14 trial several years ago. And then more recently, just like a few weeks ago, we have approval of venetoclax plus acalabrutinib, two oral drugs together for patients with frontline CLL. Well, so we have continuous daily therapy, we have time-limited therapies. I think for a young patient, let's suppose you have a 55-year-old patient, generally a patient's preference would be a time-limited approach because they probably don't want to be on a lifelong pill. So I think, in my opinion, the decision boils down to ven obinutuzumab outside of a clinical trial. And just more recently, we have another option available with ven acalabrutinib. I should also say that there is a third option available, which is ven acalabrutinib, obinutuzumab, the triplet. So I think in this situation, I would say I will offer all these three options to the patient, and I will have some discussion with the patient of what they want to do. There are some logistical issues involved, which are, one is more cumbersome than the other. And there are also other factors involved, like if they have a lot of high white count, they don't want to be admitted for obinutuzumab infusion reaction monitoring, then maybe doing an oral therapy outpatient may be okay. If there are a patient who really wants to get deep MRD negative remissions, really the best data is with the triplet, with the caveat that there is more neutropenia involved, there's a more logistically, it's a bit more cumbersome to do. So I think the good thing is we have multiple options. And I think it's one of those things where I can just say, do this. I give all these options to the patients and let the patients kind of help make a decision with me about these several time-limited options we have available.
So Bita, how do you think through it?
Very similarly, there are three major factors that I take into consideration. In this case, unmutated IGHV is something to be considered, and other basically disease-specific factors like TP53 mutation, 17p deletion. Those are disease-specific factors, and then patient-specific factors, age, comorbidities. We have learned, if someone has cardiovascular comorbidities, maybe BTK inhibitors might not be the best basically class of drugs for them, or if someone has chronic kidney disease, not able to handle tumor lysis syndrome. reliably, maybe venetoclax or BCL2 inhibitor-based therapy might not be the best option for them. And then also therapeutic specific factors. What are the toxicities associated with these generally well-tolerated combinations and single agents that we're talking about? I'm not going to repeat what you already heard. There are two major approaches: continuous therapy, time-limited therapy. And in time-limited therapy, now we have two FDA-approved options: obinutuzumab venetoclax based on CLL14, which has passed the test of time, and then the combination of venetoclax, BCL2 inhibitor plus covalent BTK inhibitor, which we've learned a lot from Nitin's, Captivate ibrutinib plus venetoclax and the European phase 3 trials. So a lot of it comes down to presenting the data unbiasedly to patients and mutually making a decision that fits, that very specific patient situation. But in this young and fit patient, it's about the art of sequencing, how to sequence these treatment options in a way to provide the patient with prolonged treatment-free remissions, because this patient, is going to live with their CLL for decades. So my personal preference in a young patient is time-limited therapy. And you heard about triplets and doublets. If you're talking only about doublets, OV versus AV, with unmutated IGHV, the basically amplified 3-year PFS for unmutated IGHV was about 68% versus 86%, or something around those numbers for mutated IGHV. So I still prefer obinutuzumab venetoclax if you're only talking about doublets, because the median progression-free survival for 60% of patients who had unmutated IGHV on that trial was about 65 months, which is pretty acceptable. 1 year of treatment, and then 4 years of treatment-free remission, and then their disease comes back, and they have a menu of options ahead of them to go through their CLL journey. And I always let my patients know there is no right or wrong answer. It's about what feels right to them and how to basically choose in a way that they can basically have prolonged treatment-free remissions down the road.
Bita, your favorite BTK inhibitors, do you have one, or how do you choose?
No, I don't have a favorite. I know ibrutinib has fallen out of favor, understandably, because of its cardiovascular safety profile, but it's still, I feel like what ibrutinib did for the field in terms of transforming the field of CLL, I still have tremendous respect for the molecule. But in clinical practice, between acalabrutinib and zanubrutinib, I don't have a personal favorite, but I think zanubrutinib has generated more data with the Sequoia trial. Sequoia had basically two arms, arm A and arm B, which was BR versus zanubrutinib, and excluded TP53 aberrant patients. Then they have a dedicated arm for TP53 aberrant patients. So they generated, data for that very specific pathology. And then they also had other arm D, which was MRD guided duration of therapy. So a very smart trial design. The data that we have in the frontline setting with acalabrutinib is acalabrutinib a single agent versus acalabrutinib plus obinutuzumab versus obinutuzumab chlorambucil based on the Elevate treatment naive trial. I, look at the two molecules. If someone is willing to proceed with continuous BTK inhibitor, between the two, there has been no head-to-head comparison, and, cross-trial comparison is fraught with bias, but we know that acalabrutinib, especially in the beginning, is associated with headaches. So if I have a patient with lupus and CNS involvement, it's not my preferred choice. The headaches resolve after 3-4 cycles. And, zanubrutinib is associated with about 23% neutropenia. So in some people, they have to get growth factors to be able to be on, zanubrutinib potentially lifelong. And in terms of cardiovascular toxicity, zanubrutinib is associated, at least, in the original trials, with a lower rate of cardiac arrhythmias. And what really matters, the risk of bleeding is basically equal between the two molecules. So I do not, it's really honestly asking about your favorite child. I don't have a favorite covalent BTK inhibitor. I do not use ibrutinib, but I think the field owes ibrutinib a lot with where it's standing right now.
So Nitin, any editorial on your choice of how to go with which BTK inhibitor?
Yeah, so very similar thoughts, I would say. I mean, I think so certainly, we obviously use ibrutinib a lot. I'm not prescribing any new patients with ibrutinib, where obviously I have patients who have been on ibrutinib for 10 plus years, and they're doing fine. So, I'm not switching them proactively, but because of the cardiovascular risk with ibrutinib, which have been now identified, especially in the last few years, especially the ventricular tachycardia and sudden cardiac death signal, I have asked all my patients who are still on long-term ibrutinib to ask them, at least to let them know about this potential side effects. And if they still say, I'm fine, doc, I'm just going to continue ibrutinib, that's completely fine. For new patients, new starts, so I'm exclusively using second generation BTK inhibitor, as Bita mentioned, so Zanu versus Akala. Again, really I've used them interchangeably, I guess, in just, like interchangeably in the sense, some patients I've used Zanu, some patients use Akala. I guess, I don't know. I would say the only thing differentiating in my mind, at least, and it's more a very specific subgroup of 17P patients, where zanubrutinib, as Bita was saying, has the best frontline data, prospective frontline data in one trial, which is the Sequoias trial, their arm C, where 100 plus patients with 17P deletion got zanubrutinib single agent. And that trial, has been published and reported. Well, we have similar data with Akala and ibrutinib, but that's a pool analysis of multiple trials because there was no prospective one trial done in that regard. So if a patient with 17P comes to my clinic who needs frontline trial options and they, the protocol candidate or they don't want to go on protocols or whatsoever, then I'm thinking for that patient Zanu for sure, just because that's where the best data resides. Outside of 17P, as Bita said, I think many times it comes down to, at least for us, is maybe not an option, but not an issue, but some practices, they may have a preference, or the pharmacy may have a preference or formulary that they have one drug, not the other drug. But yeah, no specific preference, I would say, per se. Some points the Bita mentioned about headache, I think that's fair. Neutropenia, I have seen neutropenia with both the drugs, actually. So, yes, I think the rate may be higher with Zanu, but I give both the options to the patients, and sometimes I just pick one or the other, depending on the time of the day.
So with zanubrutinib, do you use the once a day dosing or twice a day?
So I have used twice a day, which is the the dose which was most studied. It wasn't I know it can be given once a day, and certainly, but when I'm prescribing patients, I'm still using twice a day dosing. Though I think some patients, not on the start, I have used once a day, but later dose reductions and whatnot, I have dosed once a day. But yeah, typically it's twice a day for me.
What about Bita? Do you use it once a day or twice a day, zanubrutinib?
I use it twice a day for the exact reasons that you heard from Nitin. I try to follow, how it was done on original trials, but I also know that the newer trials, Celestial treatment naive and Celestial relapse refractory, which is a combination of zanubrutinib plus sonrotoclax, they give the option of 160 BID versus 320 milligrams daily. And I'm curious, when the results read out, if there is going to be any specific commentary on whether there were any differences in terms of tolerability and, less so efficacy between the two modes of administration.
Nitin, you kind of started hinting at it, but how does the presence of deletion 17P or P53 mutation shift your approach in a frontline patient?
Right. So, first of all, that subgroup of patients, 17P deletion or P53, we're talking about 15% or so of frontline patients overall. So decent number, but 15%, so not very common, but yeah, still common. I think that makes an important point that as a general rule, I think most of us are very good in checking FISH test for CLL, which is practically done when we see a patient from community or other centers. But I would say testing for P53 mutation, same mutation we do for AML patients and other disease subsets, is not that frequently performed for CLL patients. And I think it's an important point to remember to order P53 mutation sequencing assay as well as CLL FISH panel and IGHV. These are the three I think are the most important ones. Or once I have identified a patient with deletion 17P or P53 mutation, so again, the best data we have, long-term data included, is really what appears to be with continuous BTK inhibitor. And in fact, if you look at the CLL17 study, which was the big plenary session abstract at ASH, #1 abstract, came out in New England Journal as well. And it's a subset analysis of the main trial. The main trial conclusion was continuous augmentative therapy of venetoclax is same. PFS appears to be non-inferior to continuous ibrutinib. But if you look at a subset analysis of the patients with 17P deletion, at least numerically, the arm which was performing the best was the continuous ibrutinib. So that's a small number of patients in the study, but still kind of going in the same route that outside of a clinical trial setting, we're seeing the best data with continuous BTK inhibitor. Having said that, there have been multiple trials looking at doublets and triplets, time-limited combinations. There was an AVO study from Dana-Farber. We had a study with ibrutinib plus venetoclax in which there was a subset of patients with 17p. There was a CLL2 GIF trial from German Cell Study Group where they did ibrutinib, venetoclax, obinutuzumab for these patients as well. But we really don't have really great long-term data yet, and I think most of these patients, what we know, they tend to relapse a bit. So I think unless we know more, until there are large studies and there is a CLL16 trial ongoing, which are reported, I think for me, personally speaking, based on all the data we know, I think continuous BTK inhibitor, again, Zanu probably preferred in that regard just because of the best data it has would be the way to go, outside of a clinical trial form.
So Bita, what's your approach to a P53 mutated or deleted patient?
Very similarly, I do believe that the best outcomes are basically with continuous BTK inhibitor therapy based on the data that you just heard. So I'm not going to repeat myself, but also, it really depends on the level of comfort that you have as a treating physician and also a patient when data is shared. Even with obinutuzumab venetoclax on CLL14, about 10-12% of those patients, they were TP53 aberrant patients, either 17p deletion and or TP53 mutation. And in that cohort, the median progression-free survival was 52 months. And I pause and make sure patients understand this. It means, they take the combination for a year, they enjoyed a 3-year treatment-free remission, and then the disease came back. So can we do better? 100%, because there is data out there, especially with, time-limited oral combinations. If someone is really keen on time-limited therapy, you heard about AVO triplet data, and, even just the doublet covalent BTK inhibitor and BCL2 inhibitor, all the, long-term data needs to be generated to generate confidence. But my personal preference, regardless of age, outside a clinical trial, is either, if someone really wants time-limited therapy, is AVO based on the Dana-Farber's Matt David study, or if someone does not, mind being on continuous therapy, zanubrutinib, because of the data that Sequoia generated.
Nitin, when you do decide to use a doublet, what guides you on stopping treatment? Was it the length of treatment given on the studies that led to the approval? Does MRD play a role? How do you decide?
Yeah, so, it's an evolving question. So we have much more data actually on the doublet sense from ibrutinib venetoclax studies, right? So in some sense, in the US, ibrutinib venetoclax is kind of, not used because it's not FDA approved. But it is a very commonly used regimen in actually Europe and Canada and other countries where it is FDA approved and people love it. It's a 1-year time-limited therapy, high rates of MRD remission. In that context, especially in the context of ibrutinib plus venetoclax, there is data that longer duration of treatment for MRD positive patients at 1-year mark who are MRD positive in blood by flow cytometry, if you continue 2 years of the treatment, you will have more patients becoming MRD negative, and we have generated that data so there are some other data sets as well. However, the Amplify study, which led to the approval of Acala-Ven, was just based on 1-year duration, like 1 year of doublet. There's no extension based on MRD. So the standard FDA approval recommendation would be usually 1 year of combination is like 14 months total, and then you stop, irrespective of the MRD. However, I would say in the clinical practice, and I guess we will know again from MAGIC trial a bit more in this regard, because the MAGIC trial did allow a second year of treatment for MRD positive patients. We'll see how that data reads out. But in my clinic, I do use MRD. Again, that's not a uniformly accepted practice, I would say. People, it's not commonly available. People don't do it, especially outside of big academic centers to say. But in my practice, I do use it, and I have extended treatment duration for patients who are MRD positive. But the standard recommendation, and again, there's no fault in the standard recommendation. I think it would be just to do a time-limited 1-year approach.
Bita, how do you think through it?
Yes, I hear Nitin loud and clear. In my clinic, outside a clinical trial, I stick to the protocol. So if I choose AV, it's a question that deserves a lot of attention, a lot of research, and we have protocols to try to answer that very question. But if I'm seeing if a patient agrees to treatment outside the clinical trial with AV, again, the 2 months of acalabrutinib single agent and 12 months of doublet, because I think, MAGIC trial, as you just heard, okay, if we assume 40% of people at the end of 1 year of treatment with AV are going to achieve UMRD, it means likely on the MAGIC trial, 60% of patients will get another year of AV. So that'll give us a lot of understanding of, does that translate into long-term, basically, improved outcomes in terms of PFS? And with OV, I certainly stopped after basically cycle 12, day 28 of obinutuzumab venetoclax. And I think, when the publication, the 6-year follow-up was out, I was kind of surprised to see the 6-year PFS was 53%, meaning 5.5 out of 10 patients, 6 years later, they're still in remission. But the 6-year UMRD was 7%. So not everybody who becomes, the story of MRD is so heterogeneous and so complicated, and it definitely has to do a lot with the risk features. I don't want to talk too much, but, how IGHV mutated patients and unmutated, they, we have learned from clinical trials that unmutated patients become negative faster and they lose UMRD negativity sooner. So, do we really need to treat our best risk feature patients who are mutated IGHV to the level of UMRD? Are we really providing them with any clinical benefit? I do believe in unmutated IGHV, certainly. Going for deep molecular remission will translate into prolonged PFS, but do we need to overtreat our better risk feature patients to achieve a deep molecular remission if it doesn't necessarily translate into improved PFS or improved time to next therapy? So I would say a lot of questions. I really respect, Nitin's approach, but outside a clinical trial, I'm an originalist. I will stick to how the FDA approval based on the registration trial came through.
And I would just say, I think to Bita's point, I think I completely agree that I think IGHV mutation status plays an important role. So, right. So we know that, somewhat counterintuitively for these doublets, IGHV mutated, they tend to remain more likely to remain MRD positive at 1 year mark. Unmutated patients, which are traditionally high risk, are actually more likely to become MRD negative or undetectable MRD. So I agree that IGHV mutated patients, if they're still MRD positive at 1 year mark, I don't think there's a big need or push or to extend the treatment duration. And, because I think those patients are going to do well and they will be fine. I think the unmutated patient, younger patients, I think that's the group of patients where I have extended treatment. Again, this is not standard practice. It's just outside of a clinical trial kind of a setting, or not a clinical trial, outside of the standard recommendation of the FDA approved. But I do completely agree the role IGHV status plays in this MRD aspect. And, I think you have to be aware of the data and not to unnecessarily extend treatment for mutated IGHV patients who will do well with just 1 year of standard treatment.
So shifting gears just to a brief discussion on toxicity. So in which patients and for which toxicities on BTK inhibitors do you plow through, maybe make dose adjustments, and where do you decide you need to move to a different mechanism of action?
So I think for, obviously with BTK inhibitors, patients get some, especially with the ibrutinib, it was more of a case, but can happen with other BTK inhibitors as well. Skin rashes, nail changes, brittle nails, those kind of, kind of a nagging but kind of significant side effects for the patient in terms of their quality of life. I think those certainly, you could decrease the dose, high blood pressure, decrease the dose. AFib, I have done the same thing, decreasing the dose of these drugs, occasionally, generally doesn't happen too much with the ibrutinib kind of a time frame with that. In terms of completely abandoning, I think this has to be something like, obviously they have a CNS bleed, certainly you don't want to take a risk. If a patient has developed congestive heart failure, their EF is 30-35%. Now, whether that's just their coronary disease, their cardiac comorbidities, that's the kind of patient, if they are on a BTK inhibitor, I would really be worried about, just because of the risk of ventricular arrhythmias. Now, granted, we have not seen that signal with second generation BTK inhibitor, But if the patient is really low EF and they have I'm just kind of worried about those patients. But I think, but AFib, which, hypertension, kind of common side effects, I think those can be managed really, really with those reductions and working with the cardiologist to manage the blood pressure and other things. Those don't, in my opinion, require default switch to another agent. Also, I think sometimes I would say patients on dual antiplatelets, I worried about if they have a recent cardiac stent, they want to be aspirin and Plavix for 3 months, 6 months, whatever the cardiologist recommends. Those patients, I worry about a BTK inhibitor with aspirin and Plavix together, just the risk of bleeding. So many situations, those situations I've actually held the BTK inhibitor temporarily, because if they have been on BTK for 7 years, you can hold it temporarily just to prevent that risk of bleeding during that time frame. So I know some of those thoughts, yeah.
But Nitin, what about an 80-year-old who's on chronic anticoagulation? What would you do there?
So, so chronic anticoagulation, again, historically, as, chronic anticoagulation, they're on Eliquis or whatever or something, except Coumadin, which not many people are these days. There's no absolute rule of not choosing BTK inhibitor. In fact, before Ven came about, or, that was a pretty common thing because patients, that ibrutinib was the only thing around and everyone was on it. Now we have options. We have Ven-based option, non-BTK option. So I do agree. I think for older patients, it becomes a bit of a challenge. If an 80-year-old who is on some Eliquis or some other anticoagulation, should I put them on a BTK inhibitor, which will be easy logistically for them at 80-year-old? Or should I push them to Ven-G, which logistically can be quite a bit for 80-year-old, depending on their frailty status, how far they live from medical center. The creatinine could be, in fact, I saw a patient today, a similar situation we were discussing. Creatinine is like 1.8, GFR is like 35, 40. Should I push Ven-G? Or should I just say, okay, there is a risk of bleeding, but BTK inhibitor will be logistically much easier. And I think I have many times resorted to a BTK inhibitor in this situation, explaining the patient the risk involved. And I think that's fair as long as you discuss with the patient. So I'm not proactively just saying, oh, you absolutely can't get a BTK inhibitor. We have to do Ven-G and push them to that route. So I think the option is still available, even if a patient is on anticoagulation.
So Bita, another question for you is like TLS monitoring on venetoclax. It is obviously a chore. And what are your recommendations for community oncologists regarding initiating venetoclax-based regimens? What is the gap between guideline recommended monitoring and community feasibility actually look like? And how can we address it?
Yeah, before answering that question, I'm actually, I acknowledge that I'm pretty in terms of TLS management because at academic centers, there's a village that takes care of patients. But, with obinutuzumab venetoclax, I do believe that the risk of tumor lysis syndrome has been a little out of proportion to the reality of what's happening. So if you look at the obinutuzumab venetoclax trial, they have 216 patients of obinutuzumab venetoclax. And, basically, I want to say 3 out of 216 patients developed lysis syndrome, and that was just not even clinical tumor lysis syndrome. It didn't meet the clinical criteria. So the way that this trial is designed, meaning giving 3 grams of obinutuzumab, 1 gram weekly until you get to day 22 of starting venetoclax in a 5-week ramp-up fashion, 90% of the tumor bulk has been decreased. So I'm more worried about tumor lysis syndrome and infusion-related reactions with the very first dose of obinutuzumab. And honestly, if someone has bulky disease defined as an absolute lymphocyte count of above 25,000 or lymph node, either, basically extensive lymphadenopathy or the definition, any lymph node in short diameter greater than 5 centimeters, those are patients that I admit to the hospital. Sometimes you really need to go very slowly with even the test dose, 100 milligrams of obinutuzumab. And it's a magic drug. Honestly, patients get admitted with a white count of 140,000. They get 100 milligrams of obinutuzumab. The day after that, you want to give them 900 milligrams. A good number of patients, their basically white count is less than 10,000. So the debulking happens pretty quickly. And of course, that's going to overwhelm the kidneys in terms of tumor lysis syndrome risk, in terms of infusion-related reactions. But once you get them through that very first infusion of obinutuzumab, the rest of it goes smoother. So I want to just bring it to everyone's attention that more focus should be given to the first few doses, mostly first dose of obinutuzumab. And by the time they get to day 22 and they start, basically venetoclax 20 milligrams is 5% of the real dose, 400 milligrams, and they have 5 weeks to get there. And so the risk of tumor lysis syndrome with the pill and ramp up, what I do now that I've given this regimen enough is I check labs at the beginning, in the beginning of each dose escalation. And if labs are good, I don't even bring patients back for repeat labs. I encourage everyone to stick to the protocol, but in my experience, more focus should be given to the obinutuzumab part of the treatment. And venetoclax also, when you start the venetoclax, I really encourage my community physician colleagues not to have a very numeric approach to neutropenia. You heard through the lines, between the lines from Nitin, that yes, the rate of neutropenia is one thing, but when you look at the trial, always go to febrile neutropenia and infections. And the rates of febrile neutropenia and infections, even in patients with grade 3, high-grade neutropenia, is much less. But I see patients getting prematurely dose reduced with venetoclax. And if you're thinking about time-limited therapy, you want to do anything, everything to get the full dose of treatments to these patients during that time period.
So let's wrap up our discussion on the frontline treatment. But before we do so, Nitin, what are your key takeaways for our community physicians from our frontline discussion?
Well, I think one thing is that we have multitude of excellent therapies available to us, right? And I think there are some coming. Like there are some frontline approaches, especially dual oral therapies. There's a trial called Celestial trial, which is coming along. So we will have multiple excellent either time-limited approaches coming. I think the field in general, outside of 17P patients, is moving to time-limited approaches, especially for patients the younger age group side. And as I said, multiple options available. And again, I think some of these approaches require the genomics of the patient preference, kidney function, recent heart failure, AFib. Those things can help you decide, are you going to more go a BTK route, or are you going to do a Ven-Obin route? So to me, I think, and the best part, I guess, and I tell my patients these days, there have been at least 2 studies recently where they looked at the survival of these patients who got frontline ibrutinib or frontline ibrutinib venetoclax on trials. And they looked at their survival and compared to the aged matched general population of the same age group, and survival is the same. So basically, I'm telling my patients these days that for most patients, not all, but most patients will have a normal life expectancy with the we have available today. And there are some really exciting drugs coming down the line, BTK degraders included. So I think we are doing excellent in the context of CLL therapies for our patients.
Bita, you get the final word.
Yes, I would say just know the data and discuss it unbiasedly with patients. Patients' voice matters. And there is no, as you just heard, there is no right or wrong answer. It's about administering the treatment that the patient is choosing and committing to, as flawlessly as possible. And knowing that when and if the disease comes back, these patients still have already good options and evolving, outstanding strategies coming along, so they will be fine. And I hope, if someone has TP53 aberrant disease, my recommendation to my community physicians is if they can, they should definitely refer to an academic institution for these patients to be considered for clinical trials, because it is still an unmet need in the field of CLL.